Uh, the next interviewee is Dr. Patrick White. Dr. White is a palliative care specialist and the chief of palliative medicine in the Department of Medicine at Washington University. Welcome.
Thank you. Glad to be here.
Why don't you tell us what your your current practice model and position is like? What do you do?
Absolutely. So a big chunk of my job is helping to oversee the Division of Palliative Medicine at Washington University, where we have both a clinical program where we've got a team of amazing doctors, nurse practitioners, social workers, and chaplains that primarily go out and help with complex goals of care discussions. So they go into the room when patients are at a really challenging point in their hospital course and have that discussion about what is really important to patients and families. And then the second piece that we get to do is to help to alleviate symptoms. Dealing with these patients with often really serious illness, we get expertise with helping to treat conditions like pain, nausea, delirium, shortness of breath. And so we'll go in and kind of help to relieve those symptoms in challenging cases. The second part of what I get to do is oversee the research program for Barnes-Jewish for Washington University's palliative care. And we now have 3 NIH grants that look at things like how do we help support caregivers better? How do we use social media to give them tools to help reduce anxiety and depression? We've done clinical trials. Our last one looked at helping to relieve nausea in advanced cancer patients. So I get to work on the research end. And then the last part is administrative. A lot of what gets done in the homes is coordinated with nurses and social workers, nurse practitioners, and physicians that do home visits. So I get to help support our 650 colleagues in the home setting for home health and hospice for BJC's hospitals across the system.
So you're obviously passionate about it. How did you end up choosing this?
So in the era of Grey's Anatomy, was one of the few doctors that came to medical school that wanted to be a palliative care doctor. Everybody else was ER and surgery, Dan, back when I did it. And what it was for me, I think, is when I was really little, my father was a community pulmonologist, and he would do home visits. And to me, it was so amazing when he took care of patients with conditions like cystic fibrosis. And even when you couldn't cure, how grateful the families were. Just that you spend the time, helping to make their breathing a little easier or work on taking away their cough. And I can remember years later in church, the patients that their families would come up years later and just say how much that meant. So I think I got hooked a little earlier than most. But it's a career that often pulls in a lot of people that are mid-career, that were amazing critical care docs or oncologists that realize that they really enjoy this part of getting to support the patients and families.
So you described what the range of duties and so on are. What's a typical day like for you? What do you do on a typical day?
So, a typical day last week would be that I was rounding at our inpatient hospice unit called Evelyn's House. And I, start my morning and I get to meet with our social worker, chaplain, nurse practitioner, and then our learners on the team. We've got some amazing internal medicine residents and fellows in palliative care. And we run through and talk about all the patients. And I think what's a little different from what I do than maybe other specialties is we talk about the whole families too, and how do we get support to them, and not just their physical suffering, but what are the other elements that we can address to make them have the highest possible quality of life. And so we get some pretty crazy stories out of our work. Last week was a pretty tame week in the scheme of things. And then in the afternoons, a lot of my time is focused on either teaching or administrative responsibilities. We are expanding across the healthcare system as this field has just been exploding over the last decade.
So does your practice encompass going into the home personally?
It does. So on Thursday, I did my last home visit, and those are so rewarding. Sometimes, this is such an emotional time for a lot of families that it can be easy for there to be division within the families. And my meeting last week was so powerful. A very renowned professor, sharing with his family his exact wishes, as he goes through this journey. And he was very upfront with them about exactly what he did and did not want done. And there were a lot of tears, but it is so rewarding because I've seen it when that meeting doesn't happen ahead of time, Dr. Gutenberger. And you've seen it thousands of times. It can be a real challenge. So pulling everybody on the same page to support him, it was just so rewarding.
So, you're very positive about the whole thing, and I can't decide whether that's because this is the world's very best specialist, or if you just have the kind of personality like the kid who found a pile of horse manure on the living room floor and knew that meant that there was a pony in the next room. Is there anything about your practice that gets you down?
Well, Dan, before you say that, I have to call out the fact that I'm one of the few specialties where I have approved a pony to come to our inpatient hospice unit. And our social worker did go out and buy carrots and sugar cubes. Unfortunately, the pony was too old to travel up from Parkland, from Farmington, Missouri. But there are some emotionally challenging situations we see. I can think of one I had last year, where I had a patient who had metastatic breast cancer and was pregnant. And she was a young graduate student and had to choose between saving her baby, which she ultimately did, or herself. And those situations are tough. And I know a lot of oncologists and palliative care docs that have really struggled with dealing with some of the emotional challenges in our field. But I think having a really good interdisciplinary team, we've got great bereavement and chaplains, and really focusing on self-care, which I think the medical field, I'd be curious to hear your thoughts, but has done a much better job of the last 5 or 10 years of talking about self-care and really, how do we pull each other up through the tough ones? Also, to full disclosure for any amazing trainees out there, we are not the highest paid field in the world. So you do not become a palliative care doctor to make the big bucks.
So, you've segued into another area that's of interest to residents, and that is about burnout and so on. Do you find that that's a problem, or have you experienced that?
Unfortunately, with colleagues, and they've been in all different fields, I've had 5 of my colleagues take their lives at the different institutions I've been at that I knew personally well. So it is something that, and they've been all different fields. I think it's an incredibly important topic. And sometimes it seems that it gets swept under the rug a little bit and nobody talks about it. And I think in some ways that can definitely do more harm. I think being proactive about it and finding ways that you can use those emotions to make you even stronger and to help other people keep that compassion and empathy. I think that's really important, as well as getting work-life balance, which it's really important for me that the people that are in my group, that they also have that focus outside of, their healthcare setting.
How do you achieve work-life balance yourself personally?
I mean, I think part of it is you really have to, in a job like this, I can be on call 24/7 for stretches where I've gotten really connected to a patient and I want to own any of those calls. And so it's really important you set time to unplug and take vacations. We debrief with each other, as well as we have an amazing bereavement team. And each week, one thing we do that might sound a little goofy, but when each one of our patients dies at our inpatient hospice facility, we paint a rock and share a story about that patient. And for us, it's been really therapeutic. We've had no issues with burnout compared to some of the other centers I've seen. So I think it's a mix of work-life balance, and then really focusing on the impact that you've made. I think really helps out, and remembering the big picture. Yeah.
But what do you do with the rock that you painted?
So we have a rock garden in the atrium of our facility, and we keep each rock there. And it's kind of to us, it's awesome to see all the lives we've touched. You know, I was just looking at our data from last year. It's 97% of the families rated the care of their loved ones as excellent, the highest tier. And you know, you compare that to, you know, when I've been in the ICU, it's around 40% of families rate the care of their loved one as excellent. So you just think about the huge impact that you can have in this field. And you really get to know patients, Dan. You get to spend the time with them. And even if it's only for a few days, the emotional bond you form with that patient and family, I don't know that there's other fields quite like it.
So you alluded to needing to get time away. How much vacation time do you personally take each year?
You know, because of the university, you know, we get 5 weeks of, probably around 5 weeks when you include CME. But we also do other things you know, I'll take some time and focus on research and you know, just if I'm feeling a little bit burned out, kind of switch my projects around for a week. You know, there's all sorts of things within the field that I think energize us. For some people, it's teaching. We work with such an amazing team of residents and fellows, and I love working with our palliative care fellows. But the research program for us has been growing really fast. We hired 3 PhDs in the last year, and I've loved getting a chance to work with them and learn from them. So, you know, I think for us, changing up what we're doing is really helpful, and we try and switch off service pretty frequently.
Do you have children?
I do. I have a 7-year-old daughter and a 5-year-old son, and yeah, getting that time with them, you know, there's nothing better.
Do you find that you have to structure that formally in order to ensure that, or that happen organically?
That's a great question. I do try and block out time for them. And my wife is a gastroenterologist, and so together, you know, we try and make Saturdays, you know, our days for the kids. And then we kind of hold to do our documentation if there was spillover from the week till the evenings. You know, and so that's been something that we've had a lot of fun with. We've been to like every park in Missouri, it feels like, over the last year, with our indoor options a little more limited. But yeah, I think that it is really important to carve out some dedicated time.
You talked about not being, especially where you get rich. Do you feel fairly compensated?
Um, Yes, you know, I think I love what I get to do, and there is a significant range. I will tell you that, you know, doing this and getting more into population health, and I've gotten to work with some really amazing people in our ACO, the BJC ACO, and those are have been offered some very lucrative opportunities kind of related to that. And always pass just because I love this work. We've got a couple big initiatives now. We just finished a machine learning project to identify high-risk patients. We're working with the outpatient primary care team to get these patients support much earlier and have these talks earlier, and building a communication skills academy. So you know, this job lets you really, when I think back to, you know, the brief time I was a hospitalist, it lets me address a lot of those areas that I thought, gosh, I would do this a little differently, because of the way medicine is and the pace that people need to work at.
Given your early focus, focus on the career that you've chosen, was the stint as a hospitalist to coordinate with your wife's fellowship, or was that?
Yes, you're exactly right. It was right before we both did our fellowships and my PhD work. It was an amazing year. Dan, we took 4 months and traveled around the world. So that would be my other pearl of wisdom for any trainees, because you never get that time back without kids. It gave me really great perspective, and I really enjoyed being a hospitalist. But like I said, I kind of knew going in that I was really interested in this area of palliative medicine.
So it's fair to say then that your job back here at WashU, is that your kind of real first post-training job?
I I was the chief medical officer for the University of Pittsburgh Medical Center's program, hospice program, UPMC. Um, so that was my first kind of real job, and then they hired me back to be the chief medical officer here, and then to be the chief medical officer for home health, and then I added on to that the kind of palliative care roles. Um, and those systems are very similar. Pittsburgh and Wash U are both heavily academic, kind of Midwestern sports towns, and I really learned a lot from both places.
What do you think you learned from negotiating for and taking your first job that you wish you'd known?
So I got to tell you, that is such a great question, because when I first went into it, when I went from that first to a second job, I doubled my compensation. And so, I think at first, and while I was, doing a lot of graduate work and interested in research, I got really into value-based care. And the UPMC, it's called, they own their own health insurance. So there was a much bigger focus for value-based care. And that became a really hot area, which gave me a lot of really wonderful opportunities kind of coming out that, you're right, had a significant impact on compensation.
What did you learn about how to negotiate? Or
So the big one for me was really to start the negotiations with, what are your stakeholders? What are the points that they really care the most about? So for me, there's five, right? It was the inpatient mortality index. It's things like the patient experience, it's hospital readmissions, it's hospital length of stay. So you figure, like, what are the areas and then you show your track record for addressing those key areas, and what is the programming you're going to do. And for me, that was, I was able to use that as some leverage, and really had a chance to get fair compensation.
so it sounds like you're pretty happy in both jobs. Did you identify any red flags or any things that made you hesitant about taking either job, or that needed to be fixed before you would take the job?
For me, it was making sure that the resources were there, not necessarily for me personally, but for the vision for how we wanted to build the program. So for me, part of it was, I really wanted there to be a high quality inpatient hospice unit. And so negotiating to make sure all the resources were there to not just build it, but to keep it fiscally supported with a proper endowment. And then, when I took the WashU job, it was a bigger focus on adding that to what I was doing, were the research packages, so that I could bring in 5-star people. And now the amazing researchers we were able to hire, we're so blessed. I mean, we've got 3 R01s now. So our research funding, went from 100,000 from the NIH to 8 million in a 2-year period. Having kind of a map of what you see, how you see this unfolding, is really important, and to kind of have your larger vision in mind. And even if it's, your focus, my wife is interested in being a clinician educator. So her questions are completely different and less about money and more about, would she have the opportunity to work with fellows and teach GI? And she wanted to build a niche in amyloidosis. And would she have mentorship, which is really important if you're going to be in the academic area? So I think it's just thinking ahead of time, what's most important to you, and making sure that the setup you're going after, that it's got, the potential for you to really maximize your opportunities.
Do you have any advice for people like yourselves who are two physician couples trying to negotiate a job in the same institution or the same city?
I think it has gotten a lot easier with the couples match compared to years ago. But I think more and more institutions actually realize there's advantages to that. And I think in some ways, some really good places will try and recruit you both, knowing that you're more likely to stick around and that you've got a built-in support network. And even some of our research overlaps. So I think one of the most important things would be when you're starting the interview process to have the two supervisors get in touch and maybe make sure that it's a true joint recruitment, because that'll make things a lot easier on everybody. And then to know that how important listening to your other half is. They may ultimately, you want to make it the right fit for both of you. And we went to a lot of pains to really make sure that it was the right fit for both of us.
Good. All right. Well, you've been involved, at the system level in two institutions now, and you've been involved in it sounds like in an accountable care organization. Do you have any thoughts about what's coming down the road in medicine in general and internal medicine in particular that it will impact on people who are finishing their training today?
Yeah, absolutely. And that's where I love working with the accountability care organization. The head of it, there's a couple wonderful doctors, Nathan Moore, that I work really closely with. And I think we both see that value-based healthcare and bundled healthcare are going to be a really key piece of the future. So getting away from a lot of the fee-for-service mentality that really for Missouri, was the predominant payment mechanism. And they're really looking at the future of how do you think from a population health standpoint and keep people out of the hospital in the first place? And for me, a big part of getting into home care is that I think more and more of healthcare is going to be out of the hospital as technology keeps getting better and better. And we've been doing studies and doing more remote monitoring. In some ways, the pandemic really let the genie out of the bottle. And so much of what we do now is virtual, which really saves a lot of wasted effort and resources. We can see so many more patients than driving all the way across Missouri. So I think the future, if you ask me, is that the government's been pretty clear on both sides that it's going to move more towards this value-based payment mechanism, and commercial payers seem to be following suit quickly.
I'm on the search committee for the hospital medicine division chief, and one of the candidates expressed the opinion that a wave of the future is home-based hospital care.
Yeah.
That is to say, increasing the resources for care that are available in the home to the point where they resemble, hospital level care through increased nursing visits, through technology, as you alluded to. Do you think that's correct? Do you see a role for your specialty in that area?
Absolutely. I mean, that's what my specialty does, right? Is manage seriously ill patients with complex medical issues. and by being really proactive in managing symptoms, as well as making sure that we're catching the big picture. You know, a lot of patients return to the hospital because their caregiver just isn't confident what to do next. And if you get them that support and information, we think we've got a real opportunity to reduce hospitalizations and, more importantly, really enhance the patient and family experience, so that they can be there with their loved ones. I think, you know, I think all of us that have been doing medicine for more than a decade would say we see way too many deaths in the ICU that don't need to be there, where there's no benefit, and it's going to be a much worse outcome to the patient and family. So getting that support in the homes, that has been a huge focus of what I'd love to do.
So as we come to the end here, are there any questions I haven't asked you that I should have?
No, I think, you know, I mean, the only other one, you know, getting into why palliative, you know, I love the fact that for, especially when I'm doing the hospice component, a lot of times my patients aren't going to want to go back and see the endocrinologist and the infectious disease doc, you know, so we're managing all sorts of different conditions, kind of like the old school doc with the black bag that went out to the house. Yeah, and for me, you know, getting to know somebody in their house, getting to learn up on all their issues, including their derm issues, their ortho issues, you know, getting to manage everything, is so rewarding, because the families and patients are just so grateful that you supported them in their home, and you really get to know them in a way that I think in some of the other specialties, the time demands make it a little trickier. So that would be the only other thing I'd say is, you know, that I love that piece, the more holistic piece of palliative medicine and getting that real time with patients. But thanks so much for this opportunity, Dan. It's been a pleasure.
Yeah, I'm very grateful for you taking the time to do this. Thank you.